Okay. Do you consent to recording with me?
It's been a few dates, and I feel like it's going pretty well. And yeah, I consent for you to record me.
Well, good. I was hoping that you would record with me. Otherwise, the dates would have had to stop, to be honest. Welcome, everyone, to the first podcast of the Math VMeds podcast. This is actually our second one as we started counting from zero, which was kind of a practice podcast. My name is Paul Verbeek. I'm an assistant professor of mathematics and computer science in the teaching stream at the University of Toronto. And I'll let my friend Matthew introduce him.
Oh, hi, I'm Matt. I'm a critical care physician, so I specialize in life support. I've been in independent practice in Ontario for the last 7 years. And the last couple of years, I've been an assistant professor at Queen's University as well.
That's grand. So I suppose this gives us some credibility to talk about some numbers and some medicine.
Yes. Yeah.
Cool beans. Cool beans. We've established credibility. So I mentioned I did, or me and Matt rather did a practice podcast, and we gathered some feedback from that. So now we're going to respond to some of that feedback. So questions to you, Matt. Are you sure hospitals are not overrun, right? Given how much we've heard about it in the news and hear support for our frontline workers on commercials and on the radio?
Well, I think it's patchy. I think that overall, it is definitely the case that hospitals are not overrun. I have privileges at 5 hospitals. None of them are overrun. Every morning, I get an email from Critical Care Services Ontario showing a breakdown of each region in the province, what ICU capacity is looking like. And on average, we're at about half capacity. There probably are, like in any statistical sample, there's going to be a few outliers that are overrun. But you have to remember that there are hospitals that are overrun in this province every day of the year. The total amount of hospitals being overrun right now is at an all-time low. So yeah, I am sure on that point.
Is half capacity low or average, or what normal capacity would you say?
It's ridiculously low. It's crazy low. It's unheard of. It's unprecedented. Most of the hospitals that I work in average at 95% capacity. There are hospitals like in Brampton that usually are running over capacity. Their average capacity is 105%. So we have flattened the curve. We've preserved hospital capacity to a unimagined degree.
Okay, well, I suppose this leads well into our next question. So what has the impact of COVID been on the healthcare system so far?
It's been terrible. And in my view, it's not the COVID that has wrecked the healthcare system. It's the lockdown. So like I said, I understand the argument for preserving capacity for a wave of pandemic patients, but we have made far more capacity than we thought was possible, and it's been at the expense of all the other sorts of care that our healthcare system offers. We know it's like public health 101 that acute care is the most downstream intervention that you can do. Someone's sick showing up to the hospital, you've probably already missed the boat. That doesn't mean you don't do everything you can to help, but preventative medicine, public health measures like sanitation, et cetera, are so far ahead of acute care medicine. And so one of the things that's been canceled is all these elective surgeries. So people with non-urgent cancer surgeries, or with really bad joints that need to be replaced, or elective heart surgeries, these are being canceled like gangbusters in order to preserve capacity that it turns out we didn't end up needing for the last 3 months.
Interesting. And we will go into some more details about that in a minute. What is the PPE, or the personal protective equipment situation at your hospitals? Do you have an adequate amount of them? Do you feel safe at work?
I do. I have, in the last 3 months, never put myself in a position where I felt like I didn't have proper equipment, or that I couldn't deliver necessary care because I didn't have proper equipment. I know that the institutions that I work at were stressed that they were almost running out. And that was more of a supply line issue, I believe, that so certain countries weren't shipping us the materials that they usually ship us. So it was more akin to the toilet paper hoarding that went on early in the pandemic. I think most of those issues are sorted out, and but I don't know. They don't publish data on how many boxes they have in their warehouse, that sort of thing. I can only speak from my experience. I haven't had a problem.
Well, for you, that's good to hear at least. The next question is, in what ways can quarantine hurt? In the previous podcast, we made sort of a flippant remark to quarantine hurting. I'll do one and then you can do another. So one thing that happened, so remember, the quarantine was supposed to be a stay in place order. In pandemics, long distance travel is quite harmful in terms of spreading the disease. So stay in place order is quite sensible, but what we did on Ontario didn't end up being a stay in place order. At the universities, for example, we took everyone who was staying in the dormitories, sort of 20-year-olds who would have otherwise totally recovered from COVID, were sent back home to spread the disease to their parents, or worse, even to their grandparents, perhaps fatally. So that was one way. Matt, do you have another?
I have so many more. Like, we could do a whole
As many as
podcast on
you
all the
do.
ways
Okay.
that quarantines hurt.
Do
Like,
your top three. Do your top.
unemployment. We know unemployment causes suicide, depression, substance abuse,
Doubles the risk of suicide.
domestic violence. So you have domestic partnerships fraying because they're living in a basement apartment together and end up literally at each other's throats. So domestic violence calls to police have gone up 25%. The poverty. So if you take livelihoods away from people and they aren't able to do all of the things, there are so many ways that being impoverished put your health at risk, and the amount of poverty we're creating are going to do all of those things.
Okay, those were good three. The next question, and this was a popular one, and there seems to be a great deal of misunderstanding here. When you die of COVID, so to speak, was a test performed determining this?
So it's going to be different in every jurisdiction. And I think that the way in Canada and in the United States that cases and deaths are determined is different. So for the most part, cases have require a test, a positive test to have been performed. For the most part, deaths, if you see a chart or a table of deaths, that's usually from death certificates. And the way a death certificate is done is the physician who is responsible for the patient when they die fills out a form, and at the top of the form it asks what was the cause of death, and that physician, in their best judgment, they have no reason to lie, but they may not have all of the information, and it's often an educated guess. That physician makes an educated guess, and that's, if they write down COVID, then that shows up as a COVID death in our tabulated statistics.
Okay, so to be clear, there are a non-zero amount of deaths that were recorded of COVID that do not correspond to a laboratory test, but rather to the best judgment of a physician.
I know that is certainly the case in the United States. I went in detail through the CDC methodology, and it is certainly the case that if a physician tagged you as COVID, you are counted as a COVID death.
What about Canada? And
I
specifically Ontario?
I have not been able to find that detail of methodology.
Oh, that's fine. So, but at least in the States. Okay.
Yeah, and I presume it's the same here, but I don't know.
Okay. Next question. A claim was made that the government is forcing people to stay inside, whereas nobody is being forced to work. However, isn't stopping quarantine forcing people back to possibly unsafe work? Okay. So I think the confusion here is because of the use of force. I'm using this in a very particular manner. By force, I mean government compulsion, possibly at the end of a gun, possibly at the risk of being thrown in a cage. If you owned a cafe at the moment and you decided to open it, saying, screw you, government, and people came and patronized it, not sitting the adequate distance apart, or even being there in the first place, the government is going to send people with guns to tell you to stop doing that. Whereas if we reopen the economy and you elect to not go to work because you feel endangered, no one with a gun is going to show up at your door to force you to do so. That was something you made entirely of your own decision. Now, this sort of goes into a larger debate about what the role of government is, which we'll leave for another time. But Matt, do you have anything you'd like to add to that?
No, that's exactly it. To me, force means physical force. If I tell you, Paul, cut your hair, I'm not forcing you to cut your hair. If I say cut your hair, I won't podcast with you. Still really not force. If I show up with men with guns and put you in handcuffs, that to me is force.
Yeah, like let's pause and appreciate that that's what the prescribed reaction for getting a haircut at the moment would be.
Yes.
Okay, that's a little bit absurd. Uh, Number 7, loaded question. Do you have enough ventilators in the hospital? And why was there
Yeah.
so much concern about them at the beginning of the pandemic?
Okay, that's a gigantic question, and I've written rather extensively about this. But so when I talked about ICU capacity, and I get the emails every day for every region in Canada, that ICU capacity includes ventilator capacity. Kind of what defines an ICU bed in a lot of in a lot of ways is the ability to ventilate. One of the reasons why we have enough ventilators is it turns out that physicians are finding in this pandemic that a rush to put people on ventilators as soon as possible is probably not helpful. And so the rate at which doctors are putting people on ventilators for COVID pneumonia has gone down.
Okay, great to hear. And if you want to read more about ventilators, you can find Matt's work in The Guardian and
Spectator.
Spectator. And
Yeah.
that's the UK ones you should be looking in. Okay, another question. This is more of a statement or an accusation, I suppose, or indictment. Maybe you should talk to a frontline doctor rather just some professor in his fancy ivory tower. So I think there's a little bit of a misunderstanding about why you have a professor designation.
Yeah, I mean, shots fired, but I'm happy to answer it. I am a frontline doctor. Half of the work I do is at the university, half is in the community. So when I do my community job, it's me directly providing care to patients. When I work at the university, like my academic work is teaching, so I'm at the bedside teaching junior doctors. I shaved my beard since the last podcast, but I like to think that I'm older than I look. I've been in practice for 7 years. I'm teaching junior doctors, but I'm still there. And if they have trouble, then the buck still sort of stops with me, and I'm putting my hands on patients every day.
Okay, so you are indeed a frontline worker. Not all
In the
heroes
spirit.
wear
Yeah, clap
capes.
for me.
Some wear lab coats or physician coats,
Garb. Yeah.
garb. Okay, so let's just jump into the current status of the COVID virus in Ontario. I want to be really clear. I really want to delineate this conversation as much as we can to Ontario in Canada. The purpose of this podcast, the reason Matt and I have gotten together is because we want to try and help everyone understand what's the risk of COVID to certain demographics to you. How much should you be worried about it? And to give you some confidence to go back out, right? To go back to normal in some sense. So let's just get along with it. So here are the total number of COVID cases, which is the sum accumulated of all cases. So it's important to understand in this first graph, this is never going to go down. This is simply the count of the number of people we have detected with COVID in Canada over day to day. Right? This will always go up, and at best, in some sense, it will flatten. Right? So don't be tricked if you ever see this on TV and they say, "Look at this going up." Well, it's always going to go up by definition. So, what I'm much more interested in, really, the only relevant thing in this pandemic is the number of people who are dying. Right? The number of people who are contracting COVID and not noticing really isn't that much of an issue. Aside, of course, that those people can transmit the disease to people who will have a worse outcome than that. However, it is good news that the number of people dying from COVID seems to be dropping. We seem to be over the hump, or at least the first hump. Do you want to say anything about the trend of the pandemic?
I know it's your favorite point, so I'll draw attention to it. That first graph at the top of the screen is a cumulative case count. And there's been all sorts of lazy journalism where a CBC writer will say, the Premier of Quebec outlined his plan for for reopening schools as cases continue to rise. And then they'll show a graph like that.
Okay.
The cases can only rise.
So let's
it's the
drive
total number of cases.
Let's drive this point home. Okay. What this chart is, in fact, is is the number of people we have currently detected who have COVID. That's why I was very careful to say it that way. If we had perfect science, we would have done a COVID test to everyone in Canada. Now, if we did a test to everyone in Canada, how many people in Canada would we expect to find who had COVID? Well, in science, we can do randomized testing and sort of extrapolate from what we find from a smaller population to entirely to all of Canada. Now, they've done some tests in Alberta, I believe, and the last I read, they were finding COVID prevalence of about 5% of the population. My father was telling me that that number has actually increased to 10%. So the population of Canada is around 30 million. 10% of 30 million is 3 million. So this graph, the first one that we're looking at, would at least have to go to, at minimum, to 3 million. It's currently only at 27,000. So it has a long way to go to get to 3 million. So this is like downright deceitful what they're doing in the media showing this graph, right? So again, just focus on fatalities. Like really, that's the most relevant thing, and that's what we'll be doing for most of this podcast is just looking at fatalities. And as fatalities drop, I get the suspicion that the media is really going to start pressing cases now as being the problem because all of the death counts are dropping. But that's my tinfoil hat assessment of the
Yeah,
situation.
I mean, so
Let's
with
see
the
how
caveat that the deaths lag, so the average person who dies of COVID dies 2 weeks after they get it. So like there is a sense where the case count could be a canary in a coal mine. If it goes up, it could just be that you're either testing more precisely or testing more often. But the deaths are going to be a lagging indicator, I freely admit, even though they're a better indicator.
No, but like if I went out tomorrow and did 1 million tests, or I guess, yeah, 1 million tests, 10%, you'd find out you'd have to add another 100,000 to this, right? This at the moment, this is totally a function of the number of tests we conduct.
I'll push back on the word totally. It is a function of the number of people who are infected plus the number of tests, as well as the number of tests that you conduct. But yeah, it is largely a function. Okay, great.
Well, especially that it's because it's so small at the moment.
Yes.
We've detected what, like 24,000. So whatever 24,000 is 5% of is probably the number of tests we've done, which is not nearly enough.
Enough for what purpose? Like it doesn't serve. So people are shouting test, but if you're testing people who are asymptomatic, who are quarantined at home anyways,
Yeah.
I'm not sure what the
I
tests
actually
are
heard this was going to be a big waste of time. But in any case, it would be nice to have some idea, like better idea of what is the current status of this COVID, besides just relying on projected data, which has ended up being really predicting poorly. And we'll go into that in much more detail.
Yeah.
Anyways, in summary, deaths going down, things improving, at least in Ontario and generally throughout Canada. So we're now going to go through the risk by demographic. And this is really one of the things we feel is going to be our strongest point. Because as you will see from the data, I suspect that most of you watching, the risk to you of dying of COVID is totally negligible. And thus keeping you locked inside is very pointless. Right? So I'm going to hand it over to the professor of medicine to talk about this because he's much more credible in this arena than me. And I want to borrow that credibility. That's why I brought him on. So go now. Okay. Right. So this, I'll premise this chart with that I'm like sort of suspect of it. It's very difficult finding these demographic breakdowns. A lot of them are in PDFs in like policy documents and like aren't really Googleable in that sense. This is really the only demographic breakdown data I could find from Canada. As you see, the total number on it is about 2,200 when we know we have 6,000 cases of COVID deaths. So this is out of date, but it's still data which you can talk about.
Sure. Hopefully, maybe in post we can throw up the reference for this table. But and this is not one that this is not from a policy document that I'm familiar with, but it is in line with the age stratified mortality everywhere else. So there's data from Holland, from Spain, from England, from Pennsylvania, from New York, and this is about the mortality profile with respect to age. So 0 people in this data set in Canada up to May 22nd under the age of 19 have died of COVID, out of a total of 2,300 people who died of COVID. The majority of the deaths, the super majority, more than 2/3 of the deaths, have been in people over 80. Most pandemics are not like this. Infectious disease often does not spare the young. This is not that. So it looks like out of this data set, 2,200 deaths, nearly 103 under the age 60. So if I'm looking at this and I'm under 60, I have to start wondering why the government's made me stay indoors for the last 3 months.
No haircuts or else. Okay, so
and I will say, as much as I'm a critic of the lockdown, I am obeying it insofar as my hair is.
God damn, that hair is sexy, Matt.
Thank you.
Not all of us have had this advantage in the lockdown to just.
I want to review our
consent. Better looking. Are you revoking consent?
No, I'm not.
Okay,
keep recording.
Great.
Keep recording.
Okay, so to play devil's advocate, population size 2,200. I'm not supposed to say population size. I'm supposed to say sample size to not confuse people. Total sample size 2,200. Peanuts. Show me this in a larger sample size. Well, take it away, doctor.
All right. So when you showed me this table, my jaw dropped because I've been looking for something like this for so long. I called it a Black Lotus. I assume most of our listeners
the rarest Magic the Gathering card of all.
Yeah. So before we nerd out entirely, there's been lots and lots of data showing mortality risk by age, and there's been lots and lots of data showing mortality risk by the presence of comorbidity, which is a fancy medical word for other medical problems like heart disease, diabetes, asthma, emphysema. This is the only data I've seen that precisely cross-index those two things to show you the age risk combined with the underlying condition risk. And it's about what I expected, because it's rare for healthy people to die. It's rare for young people to die. I would expect it to be rare, extra rare for young, healthy people to die. And this is what it shows. So in New York City, it's a city of, I think, 16 million people, 20 people under 44 who were healthy died. So it's sad when 20 people die. But 20 people are constantly dying in New York City. So 55,000 people die every year in New York City. In terms of young people dying, there's probably 10 times more suicides than this. Probably 5 times more people die of AIDS in New York City than this. In a year, I think it's like 220 to 40-year-olds die of AIDS, which we have a treatment for. Nobody should die of AIDS. So I don't know the best way to put this into perspective, but 20 out of 16 million, you have to start really considering what your individual risk is when you're at home. If you don't have asthma, if you don't have diabetes, if you don't have high blood pressure, if you're not immunosuppressed, and you're under age 44, you're more likely to die in a car accident than of COVID pneumonia. And it just starts to get untenable to ask people to not live their lives.
No, Matthew, it is absolutely critical that we don't educate children during this. Absolutely critical. Look at the number of deaths. I think one of the very interesting pieces of information on this chart. So among the 15,000 deaths that the city of New York experienced, half of them are of people 75 and older.
Sure, but almost even of the elders, it's mostly folks with other medical problems who have died. And
only two healthy people above 75 died of this.
100 healthy people died of COVID overall. That's not good. That's a plane crash. Like, plane crashes are bad. We don't generally shut down the whole world because of one plane crash in New York City.
Okay, but I'm going to push back on you, because in a previous episode, you said one of the comorbidities could be being obese. And you don't have to be that obese, right?
No.
To now have one of these comorbidities.
Yeah, and
we should define healthy when you say 100 healthy people.
So obesity was one of them. That's important. Yeah. And you don't, I would need to gain 25 pounds to be obese.
You are fit as a fiddle, man.
Thanks. It's really nice of you. But yeah, so because people, when we say obesity, people think morbid obesity, like those I don't know, those TLC shows. But obesity is actually not that much. Like I would have to gain, I think, 30
Yeah.
pounds to be obese,
But
which is a bad winter. Like it's
yeah,
doable.
so to be fair, right? Like we're not really saying like 100 average people died. That's not true, right? 100 healthy people. If you're healthy, you don't have anything to worry about. But the average person isn't healthy, right? And
Yeah, that's true.
we're trying to assess the risk for the average person.
And the other caveat I want to make is I'm not celebrating that COVID kills sick people. Like my life's work is protecting and treating sick people. That's what I do all day. I have sick people in my family that I care about. But it doesn't help sick people to make healthy people unemployed, shut in, uneducated, impoverished in a domestic violence situation.
Yeah.
So like the fact that this data is out there, we can see it before our eyes, we have to start tailoring our approach in terms of who gets locked down and targeting the vulnerable for protection
I
instead of
understand. But like I
yeah.
just want to
Oh,
put it out
I
there
have to turn the
that
light
like
on. Keep going. It's getting dark.
yeah, that's no problem. Um, I just want to sort of say that like it's okay to be scared. Like I get how you could be scared in this environment. We've been locked outside. There's this supposedly killer disease tearing through us according to the media. And like humans are terrible at evaluating risk. Like our minds aren't designed for this, right? Which is why I'm trying to like really spell it out here. Like if you are sort of under 20, what would you say your concern level should be?
Me, or are you asking the audience?
I'm asking you
it
as
should
the
be zilch.
physician,
You should
right?
be very concerned. You should be very concerned about not giving it to your grandma.
Yes.
But you need to turn your own health anxiety down. I'm not saying that no one under 20 will die of this. There are freak accidents. There are people under 20 who die of choking on a foot long. There's people who die being struck by lightning. But it's a freak accident if you're under 20.
And the flu,
Yes.
which is a vaccinable disease, and no one gets the
Yes.
vaccine. We just think very oddly. This is all I'm pointing out. And I normally don't care, but like this is sort of a catastrophe situation where we need to make faster decisions about this disease, especially in the light of new information.
Yes.
So in summary, if you're under 20, don't be worried. If you're under 40, don't be worried. If you're under 60, don't be worried. Okay, above there, we'll have to have a more specific conversation. All categories, just try to be more healthy, right? If you want to protect yourself against this disease, exercise or STFU, right? There are measures that you can take to insulate or protect yourself from this disease that don't require shutting down and the government stabbing you in the arm with a mandatory vaccine. Right? There are steps that you can take right now. Well, that
usually depends who you are, but yes.
Yeah, very generally, of course, with a finite number of exceptions. This is just another chart taken from the US for which data is much more accessible. A little bit of a shame on you, Canada. But not to say maybe I could find this graph, but I didn't. I'd like to point out that the number of people dying of COVID at any given time seems like totally proportional to what age you are at, right? This is just in support of our point. And like, is this unusual that for this to happen in a disease? This is like a typical thing?
In a disease, maybe. In infectious pandemics, maybe not. Like, so yes, more people over the age of 85 die of heart attacks and cancer. So I think if you threw up a cancer or heart attack chart, it would probably look like that.
The same?
If for cholera or malaria or something like that, no, those things often don't spare young adults.
Yeah, it's indiscriminate in who it kills. And
yes.
more so than it is in COVID.
Yes.
It seems to have a discrimination for age.
Yes.
Okay. Just to reiterate that that's unusual in a pandemic. Speaking of pandemics, let's talk about predicting pandemics, because we haven't been doing a very good job in my assessment. Okay, so what is a model? Like they talk about models on the television all the time. Well, if you've ever played SimCity, like, which is a game where you like lay down housing and roads and stuff, and it simulates the operation of a city. It's that minus the graphics, right? At a very basic level, you just have a grid, and in every grid position, you put a human, and then you let those humans move around a bit and communicate the disease with some probability. And then you see how the disease travels through it, right? At a very basic level, that's what this model is. Now, the people who are experts at this like are adding arbitrary levels of sophistication over it, like, you know, more acute population density, like better data. But it is ultimately scientific guessing, right? That is not an exaggeration to say that. And the other important thing about guessing or modeling is that when the modeling mispredicts what actually happens, right? Game over for the model, right? That's what the model is supposed to do, is predict. If I say I have a model and it's going to rain very badly for the next week, and over the next week it's perfectly sunny every day, sorry, observation trumps models, right? And people seem to be attached to some of these models. So you got to let it go, right? Those models are invalid now, right? We tried guessing, and I'm going to show you what that guessing means, but they're meaningless at this point. We shouldn't even be talking about them. Okay, but what does the World Health Organization have to say about modeling? I was trying to investigate what we're supposed to be doing in a pandemic, because surely, oh geez, that's my Google getting angry at me. I was trying to investigate what we're supposed to be doing in a pandemic, because surely we have a plan, especially after SARS, right? So what steps are we supposed to be taking? So I happened upon this policy document from the World Health Organization prescribing what we're supposed to be doing in a pandemic. Now, I know people are going to complain that this is an influenza pandemic policy paper, but from my understanding, this coronavirus transmits similarly to the flu. So in terms of containing it, is it fair to say a influenza pandemic plan would have parallels with like a coronavirus pandemic plan?
Yes. Yes, it would. Oh, what was I supposed to give a longer answer so you could
Yeah, I was
you could
trying to
drink
like
more?
try and cut that with a drink, but that's just how the cards are dealt occasionally. Okay, but this is where like the hammer drops, because in this document, I'm just going to read this. Modeling of a pandemic can contribute to decision making, especially vaccination production and distribution, particularly in the later stage of a pandemic. In the early stages of a pandemic, it is unlikely that there would be sufficient data to predict the course and impact of the pandemic through modeling, right? From the WHO, World
Oops.
Health Organization. Don't use
Oops,
models at the
sorry.
onset of a pandemic. It's not
It's
going
like
to.
memento. It's like we tattooed this on our arm and we're staring at it going,
We should. Everyone's
what have
so
we
in love with
done?
the World Health Organization. Like, okay, let's suppose I agree, then let's follow their advice, right? And this is very obvious advice, because this is a novel coronavirus. We know very little about it, right? So I tried to track down the model that Ontario is using to try to predict how the pandemic would spread here, like out of academic curiosity, and also because I wanted to double check a few things. Now, that model is very hard to uncover. Okay, maybe I should add a few more points about the models. The inputs that are important, or at least some of them, the number of people an average person has contact with in a given day is important, right? This is basically population density. The probability of communicating the disease, that is, if someone who has COVID interacts with someone else who doesn't, like how likely it is that the disease is going to transfer, and the length of time for which someone is infectious, right? That is as important as this supposed R naught value, so-called R naught value that we have hyper focus on in the news. Right? I can half R naught and double the duration of time someone is infectious, and the lifespan of the disease is going to look about the same, right? So again, we have to guess at most of these parameters, right? This isn't magic, right? We can have more educated guessing by like collecting data and trying to work it out from there. But as I said, this is a new disease. We had very little data, right? I don't really blame them for having such poor models. Like this was, if the models would have predicted properly, that would have been more likely due to luck rather than design, in my opinion. Okay, so this is the policy paper written that guided Ford to make the decisions about lockdown, called Mathematical Modeling of COVID-19 Transmission and Mitigation Strategies in the Population of Ontario, Canada. I was reading this, and here you go. So here's just a list of these magic parameters that they've put into the Ontario models. Most of them, like, the basic reproduction number, they have references. Like, they're doing their best. I acknowledge that. But some are outright guesses, right? This relative risk of transmission for cases in isolation, that's an assumption. But they don't even try to hide that, right? 1 in 10. Who knows? Right? That's how precise this science is, right? So don't overtrust it. It's not magic, right? It's just math that sometimes works. Predicting is hard. Now, this is sort of a bombshell. I was reading the policy document and I stumbled across this assumption, which even to me as a layperson seemed preposterous. I'm going to read it. For simplicity, now remember, this is a policy document whose core intent is to estimate the number of ICU beds occupied during the pandemic, okay? And for simplicity, we assume all deaths occur in cases requiring intensive care. Now, can you comment on this? Is this a sensible assumption? Is it off? How off?
It's definitely completely wrong. Like, I want to give them the benefit of the doubt when they say for simplicity, that they're somewhat acknowledging that it's wrong. But myself and really all intensive care doctors, we are interested in bringing people to intensive care for very invasive treatments who might benefit from it. Like, we're going to anesthetize them. Sometimes we paralyze them. We intubate them. We ventilate them. We give all sorts of medications. If I didn't say, like, put them in medically induced comas, it's a rough go. And if you are an elderly person with a lot of other medical problems, we often don't recommend it. So if you are 92 years old from a nursing home, you have a leg amputated and severe dementia, 9 out of 10 intensive care physicians are going to say, I do not recommend that we engage in life support here, because it's not going to work. As it turns out, most of the people who have a bad time with COVID, who are dying of COVID, are elderly people with multiple other things wrong with them. So
do most people die in the ICU, or like, do most people not die in ICU?
I don't have that. Okay. I don't have that number, but I don't have it. I don't know it. I suspect that it's going to be well under 100%. And I don't claim to know it, but they've made a model where they just assume that it is 100%, and that's kind of the one number that I know for sure isn't true. If they said 100% or 0%, I would have said you're wrong. And I'll bet my house on that.
Okay, so 100% has to be wrong.
Yes.
It has to be. So their models have to overpredict the ICU capacity.
Unless they made some other
well, I've thought about this very hard as well. I to be honest, I don't understand it's not like I don't understand the models, but they rely a lot on like calling other models, right? So a lot of the details are abstracted away. But if they're estimating ICU capacity and they're saying everyone who dies in the ICU, then it's going to be the case that like 100% of the COVID deaths are going to correspond to the number, like exactly to the number of people dying in ICU. And that is an extremely flawed assumption.
Yes.
Okay, so let's look at the model and compare it with observation. And remember, observation has to trump the models, right? Reality beats guessing. Okay, so here is the policy document shown to Ford, all right, to help them guide this decision to put us into quarantine. The pale blue line that's going really high is the worst case scenario. That purple dotted line that it's passing is the surge capacity of our ICUs. So I suppose that's you can put extra provisions in to expand the ICU somehow, but only for a brief period of time.
Yes and no. So it's the post-operative recovery area where people wake up from anesthesia. That's the first place that we usually put ICU patients, because they know how to deal with people who are on ventilators.
Okay, so it seems that you can spin up more. It's sort of a moot point, right? So don't reflect on it.
Yeah, sure.
Hard. The red dotted line is our actual existing ICU capacity. And those green bars, right? So what you're looking at is their predicted ICU capacity throughout time from March 22nd through May 6th. And their medium, right? So they sort of took the medium estimation. And at April 7th, there's a tiny move over the ICU capacity. Now that is a problem, It is a problem that we predicted that there would be more people in the ICU than we had ICU beds. Thus, as a temporary provision, we locked everyone inside because the effect of that would be to sort of take this curve and stretch it a bit. And by stretching it, it's going to take that peak and it's going to push it down. It's going to push it down underneath the ICU capacity, which is something that our hospital can handle. Now, the pink, the thing that's well below even the best case estimates, is the reality. All right, so let's let that sink in. Prediction versus reality. Why is this a problem? Well, the only justification given for the lockdown was to ensure we didn't cause extra fatalities from hospital overfilling. This was what flattening the curve was. The models predicting this overfilling seem deeply flawed and were invalidated by observation. Reminder, we did not lock down to lower the number of deaths, which remained fixed over the lifetime of the disease, right? Assuming no cure or vaccine, right? So the number of people who will die of COVID is fixed over COVID's lifetime. So the question I put to you, anyone, why are we still in quarantine? What is the current justification for the shutdown of the economy? Because the original justification was to prevent this predicted surge of ICU capacity, which was predicated on false reasoning and didn't end up happening anyways. Any thoughts?
Right. So I mean, so people have shifted what they are now calling the rationale for the lockdown. They're saying, no, we are waiting for a cure. We are waiting for a vaccine. And I can only bring to bear on that question my skepticism, which is born of experience. That so, for instance, there was a flu pandemic in 2009. There's still no good drug treatment for the flu. There was a coronavirus pandemic would have been 2003, SARS-1. There's no treatment today for SARS-1. As far as vaccines go, so even the most optimistic people are saying a year and a half for a vaccine. We can't do a year and a half in lockdown. I can't do a year and a half in lockdown. That year and a half is terribly optimistic. So for 100 years, we've been trying to get a tuberculosis vaccine. We have one, it just doesn't work so great. So most Canadians have not received a tuberculosis vaccine.
Some people are imagining we're going to get a vaccine by September.
I think that's crazy.
Mm-hmm.
There was an Ebola outbreak in 2013, and that, by the way, was terrifying. Because if you get Ebola, it doesn't matter who you are, you're very likely to die.
Well, and it was truly airborne, wasn't it?
Truly airborne. I was wearing a hazmat suit. That was.
Aren't you all wearing hazmat suits? That's what they're showing on the CBC during those interval. They literally showed people in hazmat suits. Right later on the national.
In 2013, when that Ebola pandemic happened, a vaccine already existed. And shout out to Manitoba. It was developed in Winnipeg. It already existed. It already worked. It still took 4 years to validate it, license it, mass produce it, deploy it. I don't see us doing better than that.
But remember, the objective of this podcast is to make people less afraid of COVID. Right? Ultimately, it doesn't matter, right? Because the risk to everyone who is not old and not unhealthy, is totally negligible. Right?
Yeah, I'm defending the rationale of flattening the curve as being the only rationale that made sense. Waiting for a vaccine does not make sense.
Okay, so I'm just trying to make a case that reality trumps models, and to tell everyone how the models worked, and in some sense how they didn't work. Okay, this begs the question that aside from predicting pandemics, how would you detect if you're in a pandemic? What would observations look like that would sort of signal that is something wrong? So any idea, Matt? I asked.
Well, yeah, I think I know the answer. That if a whole bunch of bodies are piling up, if you're seeing a lot of deaths.
Right. So there's a piece of terminology I want to insert into everyone's vocabulary, and that is excess deaths. The number of so what you normally do is count the number of deaths, which actually governments have been doing fairly well throughout history. We really do have reliable counts of deaths-ish. So count the number of excess deaths. And if there's a huge spike in the number of people of dying, like over previous years, then you're kind of like, okay, something definitely is happening. So if we were in a pandemic, we should expect to see a spike in the number of people of dying, right? I have to qualify that a bit. People will say, well, because of quarantine, we have far fewer deaths. And that is going to be true. But I still think that it's important to look at the number of excess deaths despite that, right? We don't know how much of the quarantine, we don't know what effect the quarantine could have had yet, but I do concede that point. Okay, so here's some plots of the average number of people who die during the period January through May in other countries throughout the world. Now, if we look here, you do see spikes, right? England and Wales, spikes. Spain, spike. France, spike. US, spike. Netherlands hasn't even really plateaued yet. But you do see some countries like Germany, which haven't had a spike like this, right? So now I'm going to say something that may sound sort of bombastic, but there are some countries that got COVID that didn't get a pandemic, right? Using this term excess deaths, which I really think is the only sensible term for a pandemic, right? If the cooties was spreading through the population and it literally only killed me, no one would care about contracting the cooties, right? Deaths is the only thing that matters. Well, not the only thing, right? If it paralyzes you, that matters too. But for COVID, let's just assume it's death or COVID. Germany didn't really get a pandemic. Now, I expect all of these curves sort of look like Germany if you remove their major city. Like, I wonder how much these curves have to do with US having New York City or Spain having Madrid, England and Wales having London. But in any case, it is possible to have COVID without having this pandemic. That is to say, COVID is just a part of the normal, proportion of people we expect to die in a given year, which is what we're going to talk about next. Okay, so people die every day. People die every month, okay? How many people die in a month in Ontario, right? Let's just focus on Ontario. Well, according to this chart, it seems that 9,000 people a month die in Ontario, a month, right? And I think in Ontario, we've had 2,200 fatalities to COVID. Here is what people die of year over year. The number one killer is whatever a malignant neoplasm is. Strauss, take it away.
It's cancer.
Cancer. Okay. Number two is heart disease. Number three, cerebrovascular disease. Strokes. And then continuing at number 6 comes in influenza and pneumonia, right? So apparently in 2018, a couple of years ago, 8,500 people died of, influenza and pneumonia, right? So it's a natural occurrence of life that people will die of things. And some of those things are going to be diseases. So because I need the proportions now, so here's the top 10 causes of death and the proportion of people they kill in the population. So I'm going to be comparing COVID with influenza and pneumonia, right? Because I don't know, I felt that was the thing in here that it most would be categorized as. Do you feel it would be categorized anywhere else in here?
No, I think that, like there are other ways to die of COVID. There's other ways to die of influenza as well.
Okay, let me ask you this,
pneumonia,
right?
But the vast majority of COVID deaths are going to be COVID pneumonia.
Right. So like if COVID never made the news and they had to categorize it somewhere, they'd probably categorize it in influenza and pneumonia.
Yes.
Okay, so about 2.4% of the population is going to die of influenza and pneumonia. So we can do some like really rough calculations. I really stress really, but I don't know, it's good to do them. Okay, so over 5 months in Ontario, we would expect to lose 45,000 people, period. Okay, we expect 2.4% or about 1,000 of them to be dying from the flu and pneumonia. Just slide's a little bit wrong. Okay, so we've had 2,000 deaths in that period. Okay, so normally we would expect 1,000 deaths from the flu and pneumonia. That would it would be triple, right? Assuming all of those flu deaths. But another way that I can characterize this is that Ontario experienced 1,000 more deaths in a population of 15 million. I'm not sure that would register as a pandemic if we were looking at the excess deaths. I'm going to have to wait for those charts. Right? But assuming all of the 2,000, like an extra 2,000 deaths, puts you in that signal noise. So I don't think it would register very clearly. Most of those charts that we were looking at, you need a 50% increase in deaths. This is closer to like a 10% increase in death, or maybe 20. Certainly not 50 though. Okay, I have to sort of qualify this the fact that this is a novel virus is important, right? It may be equally fatal as just like flu and pneumonia regularly. We may have seen most of the fatalities already, right? Because when you drop a new virus into a population with no immunity to it, the virus gets to spread very quickly. And when it spreads very quickly, it's going to kill much, much more quickly. But as we've seen, right, the death rate's already dropping, so we should already be beyond the curve, right? So it could be the case, like, give me the rest of the year, and we can reevaluate if this number is still twice as many as the flu and pneumonia. Perhaps over a year, this will drop much, much lower. Who knows? Okay, so let's now compare COVID with other illnesses. Remember, with the objective of trying to help people assess their risk of this disease. And I'll let the doctor take it away. So here's the MD's perspective.
Oh yeah, so I love this graph. This is from Spanish flu in 1918. As Paul was saying, one of the few things government can really count well is deaths, and these are deaths in Montreal and Toronto in October, and there was a spike in the young adult range, so 25 to 30. As with other diseases, there's also a spike at the extremes of age. But Spanish flu absolutely did not spare young, healthy people. It was young, healthy people who the virus seemed to have a predilection for. So that was 100 years ago. The next slide is, this is H1N1. So that's a pandemic during my career. I was a junior doctor in 2009. I think I was about 25 years old. And you can see from this chart, the mortality risk, if you caught H1N1 for a 25-year-old was about the same as for a 70-year-old. And I remember that people were scared during H1N1, but nothing like the panic now. And I was concerned, I remember, but I wasn't locked down. And I was far more at risk of dying as a healthcare worker in 2009. And I remember that there were young people dying in the ICU that I worked in at that time of H1N1. So COVID is really different from flu that way. I've been working in ICUs. I've been taking care of COVID patients on ventilators. None of the institutions I work at have been terribly touched. So I've had about 6 patients on ventilators for COVID pneumonia. And 100% of them have been over 65 with other medical problems. So I'm not denying that COVID is out there and it's killing people. About a third of the patients I've looked after with COVID pneumonia have unfortunately passed away. But this is so different from past flu pandemics in terms of the very peculiar age stratified mortality risk.
Why are you calling it COVID pneumonia, out of curiosity?
Well, that's what all 6 of my patients had. And that's by far and away how, if you're being admitted to the hospital because of COVID, it's almost always because of COVID pneumonia. There's some very rare other presentations, like extreme, like getting struck by lightning, rare.
So
yeah, there's
like you have to have pneumonia basically to die of COVID, or like
you don't have to. Like I say, there's these rare exceptions.
Yeah,
extraordinarily strong.
Okay, so what's pneumonia then, and how do you catch it? Is it
pneumonia? Is infected lung tissue that I can see on an X-ray.
How do you get it? Why are we worried about pneumonia to the same extent we're worried about COVID?
Why aren't we?
Yeah.
Most pneumonias are bacterial and not easily transmissible. So most bacterial pneumonias are from bacteria like Streptococcus or Klebsiella or Mycoplasma. I only mentioned to say, like, most people haven't heard of these things because if somebody in your house has one of those, it's not terribly likely that you'll also get it. It's we don't fully understand why you get pneumonia when you do in most cases, and it's not your relationship to a sick contact.
Well, according to state documents, your chance of communicating COVID indoors is 1 in 10. Every day, right? So don't forget to accumulate the
right.
Just a thought. Food for thought, because you mentioned something the last time about when you like declare an emergency and call all the nurses into work, right? Who's taking care of their children? Usually the grandparents.
Yeah.
Right. So I like, again, we can investigate how many of these fatalities were actually a cause of the quarantine rather than of COVID, or
Caused by the quarantine
caused by the quarantine plus COVID.
rather than prevented. Okay, sure.
Yeah, rather than prevented. So we're going to end with an emotional appeal, right? We're just Hail Mary, right? If nothing else we said can convince you, perhaps some of these emotional arguments will convince you. So people's graduations and proms and weddings have been canceled needlessly. I don't understand how students having their prom is going to infect your grandpa, unless there's some new millennial tradition of spitting in your grandpa's face after prom. This is like we're robbing youth from some people, and some may say, well, I'm willing to make this sacrifice, but are you actually making that? Like, I'm really hesitant to make sacrifices on other people's behalf,
particularly when it just doesn't seem to be necessarily the case that these sacrifices are helping. Like, I am very interested in protecting the elderly and the vulnerable, but if you don't have any elderly and vulnerable in your household, I don't see how you going to prom is necessarily a problem. There's other things that are canceled. Funerals are canceled. So people are hospital visitation is canceled. Put those things together. So you're dropping off your loved one at the hospital, perhaps because they have COVID pneumonia, perhaps because of something else. And you get a phone call every few days to tell you how they're doing. You're just sitting there hoping for the best. Then you get the call that they're not doing well. Then you get the call that they died. And there's no saying goodbye. There's no memorial, and people are dying alone because we've
loved
decided
ones are
that
dying alone because
it's
because the
horrendous.
state says so, that we have to let people die alone.
There's more things that were canceled. Like, dates are canceled. You're 21 years old.
Well, this is an interesting point. This is something I can't really understand. Maybe you can shed some light on it, just to spitball a bit. Use in dating apps have increased, which is not too surprising because people still want to talk with people. But correspondingly, purchases of lubricant and condoms have skyrocketed. So do you?
I mean,
I can't imagine that people who normally live together are having more sex because of quarantine. I think those are the people who end up hating each other. So do you think that 20 and 30-year-olds are just running around anyways, having their dates? Do you believe that they're actually canceling their dates?
Maybe they're having hookups. That's what it sounds like. They're not.
Okay, but
they're not going for a
that's
walk in the
certainly
park.
I don't think they're going to be social distancing during their hookups.
Right.
So I'm saying
I don't know.
the disease is being spread amongst the youth, right? Despite our best efforts, young people have always been subverting control.
Yeah, you're gonna have a really hard time getting young people to stop having sex. It didn't work in Footloose. It's not gonna work now.
Let's ban dancing.
Exactly.
Which we have done, people. Dancing is banned. We are worse
It's
than the
done.
Footloose mayor. It
Yeah.
is worse than that. Look at this hair. Do you think this is something I volunteered for? No. I need a black market barber. Okay, for next podcast, some of the things that we may talk about. The effect of population density. There's some interesting things to say about population density. At one point, I had a hypothesis that population density is highly predictive, right? So you look at New York City and Madrid, London, and even in Canada, right? This philosophy pans out kind of. Montreal has 4 of the 10 densest cities, and they have a bad outbreak. Of course, there was going to be a bad outbreak in the GTA and Alberta, but British Columbia is doing fantastic despite having Vancouver. And that's puzzling to me. They have had in the order of hundreds of deaths. Now, they never closed their paths or parks, which is something that I've been quite irritated because in Ontario, we have had closed our parks and trails. They're slowly reopening, but they still refuse to open the parking lots, right? The parks are open, but the parking lots are closed.
I wonder, and I'm spitballing here, I wonder if you came up with a model that was population density plus real estate value. There's something about places like Hong Kong and Vancouver are very densely packed, but it's very affluent people who live there.
Yeah, but okay, so in the world, the Philippines has 4 of the top among the 10 top densest countries in the world, Philippines has 4. I think they're also number 1. Manila's number 1. I don't hear much coming out of the Philippines.
I
Like,
mean, so there's
unless
other,
this
yeah,
is
this is why
totally
models are
reporting.
hard. This is why models are hard.
Well,
We're only
I don't
sort
know.
of proving
Like,
the
so
point.
like this, why don't, are Asian people suffering? Do you know anything else about like the
So
ethnic
there's
breakdown of this?
obesity is an issue. The age of the
Oh, Asians,
population is an issue.
okay.
Like I
Asians,
imagine the Philippines is a relatively young country.
that's true. Less old
Anyways,
people to die. That's interesting. Well, it's just good to think of for next time, people.
yeah,
Giving you
for
a little
next time.
bit of a sample. The collateral damage of the quarantine. We've touched on this, but perhaps you've caught on to the fact that me and Strauss, well, let's say we're not pro quarantine. I'm actually very pro ending this at the fastest possible rate that we can muster, because every month we stay in lockdown, we lose a year of economic growth. And I can see businesses going out of business around me, right? So the situation is becoming dire. I also don't understand what the high schools are thinking, that they can just confer diplomas upon grade 12 students and send them to me, right? Having a grade 12 diploma doesn't actually give you the knowledge, but we'll see what happens in September when we receive the incoming year. Who knows how we're going to sort them, right? Because we don't have grades to use for admission, right? Because they canceled the second half. We really only use the last year to sort them. Those are just a few. Any to add?
No. I mean, I could go on.
We'll
About
save
this
it for next
another
time.
hour and a half. But do listeners please send in more questions? I think that was my favorite part so far. Was
it's good warm up
the
for us. It
interactive
just gets us into the groove of things. Yeah, we appreciate that feedback. Okay.
Yeah.
I also want to investigate the government response, right? Like really investigate it, go through a timeline, try to understand why they made the decisions that they did. I want to talk about the media because I'm getting pretty furious with it. I think this is about as close as you can come for being like blamed for actually killing people. Right? Well, they're scaring people away from the hospital, right? By feeding them false information. People are not going to the hospital because they're afraid they're going to catch the COVID and die. They're like, I'll just next heart attack. I can get through this one. Okay. And
that might be a more debate worthy one.
Sure. This is why it's for next time. That's why I'm also giving you no opportunity to respond. Okay. And 5, the new normal. What is the new normal going to be? Do we need a new normal? Is the old normal a good new?
I mean, I'm against cruises. Like, let's get rid of cruises. And I'm against driving places needlessly. Like, let's make everything a bike lane. And why can't you just go to the beach? Why do you need to float in the ocean for a week?
Can't go to the beach. You'll communicate the COVID in the ocean.
Yeah. But
you'll give it to all the fish. The fish will give it to the whales, and then it's endgame.
Yeah.
You can't prove me wrong. All right. Well, that's going to be it for this podcast. Listeners, if there are indeed any listeners, we hope this educated you a little bit, and we are glad to have had you. Any last words, Doctor?
Just
peace. Peace are good words.
Yeah.